All right. You all know me, and most of you probably know that before coming to ANMC, not only did I do general surgery training, but also a year of trauma and burn fellowship at Harborview Medical Center. And so I'll be talking about burn resuscitation today. So in this talk, I'm going to talk about burn care in Alaska. And then in order to talk about burn resuscitation, burn wound assessment has to be determined. So I'll briefly go over how to determine burn depth and size. And then we'll really focus this talk on burn resuscitation, going through initial and ongoing needs for fluids, rural and remote considerations for resuscitation in Alaska, and then any adjuncts and how to identify a failed burn resuscitation. So scope of the problem, we have about 100 burn injured patients admitted to Alaskan hospitals every year. This is data from the Alaska Trauma Registry. It represents about 3% of all traumatic injuries in Alaska. So it's kind of low volume, high acuity, and about 30% of these are going to be pediatric patients. But we know that those 100 patients that either get admitted to Alaskan hospitals or transferred to a hospital out of state is a small piece of the true number of burn injuries in Alaska, as many are seen in emergency departments, clinics, and maybe discharged from there. ANMC, we admit about 40 burn injured patients each year. I'll go through some data to show you that statewide, burns still remain a large reason for trauma transfers out of state. So this was 5 years of data that we looked at Alaska trauma injuries and who is being transferred out of state. And as you can see, the majority of trauma transfers are either due to a blunt trauma mechanism or burns. And in these 5 years, there were over 100 patients that were transferred out of state for burn care. When you broke down blunt mechanism, because that's kind of a big, broad category, and they broke it down to kind of body image or body injury location, so head injury or maxillofacial. If you piece it out by injury type, burns remains the #1 reason why patients were getting transferred out of state. Also, if you look at the regions, we know that Southeast Alaska has a lot of both geographic and financial ties to Seattle. And so often, we definitely see a pattern that the Southeast Alaska transfers a lot more to Seattle. And so, which is appropriate for some of those reasons. So when we looked at over the last 4 years, or 2016 and 2019, we looked at all burns from Alaska that were being transferred to Harborview. And ANMC has begun to kind of build establish ourselves as a center for specialty burn care. And again, this doesn't mean that a burn surgeon does not equal a burn center, but this has been a large effort to train up nursing and therapy staff and respiratory and in our operative capabilities so that we're able to provide some specialty burn care. And you can see that considering all burns, we saw a reduction of burn transfers out of state. And when we drilled that down even further, knowing that Southeast often will transfer to Harborview, which is appropriate, and not all burns should stay in Alaska. We do not have the capability of keeping a 60 or 70% TBSA burn. So we further drilled that down and said, okay, let's look at burns less than 20% and kind of eliminate out the Southeast. And when we looked at that, we had a reduction over 4 years from 35% of burns transferred out down to 15% transferred out. So over half of burn transfers were reduced by building capacity here at ANMC. Okay, so let's shift to burn wound assessment. When you're looking at a burn, we want to kind of note 4 things, which is size, depth, location, and mechanism. If you include these 4 things, you start to have a common language for communication with providers. We all know that telemedicine has really changed medicine, and it's been a drastic improvement for burn care over distances. because a lot of the cutaneous burns can be evaluated through picture. But even if you don't have those capabilities, you should be able to piece together those 4 pieces and give a really good idea of what kind of burn you're looking at. So even without seeing this picture, I could tell you that this is a 3-year-old with a 9% TBSA partial thickness scald burn to the chest and abdomen. You have a really good idea of what we're talking about. So let's talk about depth and size, because those will play into our resuscitation. So there's 3 depths that we'll talk about. 1st degree burns are superficial. These are erythematous, but without blisters. They can be really painful, but will not require operative care, and usually do not require hospitalization. So they're clinically usually non-significant. And so we do not include 1st degree burns in our TBSA calculation. 2nd degree burns are going to be characterized by blisters. So these are partial thickness burns. You can further define it through superficial and deep. When you debride the blister, you're going to look at the wound bed. And if it's pink and moist, then you're going to have a superficial partial thickness burn. And if it's moist, if there's a blister there, but it's moist and pale, then that's going to be a deep partial thickness burn. But really, blisters are kind of the characteristic of this. And depth for 3rd degree or full thickness burns. These are going to be very dry and leathery, and they have decreased sensation. So they may have, if you see a large burn and the patient isn't that uncomfortable, you may be suspicious for a full thickness burn. Also, they come in many colors. So you can see they can be white or dark brown or even cherry red or hemorrhagic. And those are all examples of full thickness or 3rd degree burns. Once you know the depth, we want you to calculate TBSA, or total body surface area percent. Again, this is going to be our 2nd and 3rd degree burns only. There's several ways to calculate this. Initially, a lot of people are familiar with the rule of 9s, which divides the body in integrals of 9. The important thing to know is that kids are different, so their heads are bigger and their extremities are smaller. And so you do have to put that into consideration. If you have a smaller burn, the Palmer method can be really helpful. And you take the patient's palm, not your own. And it's not the colloquial palm that we think of, but it's wrist crease to fingertips of the patient's palm will equal about 1%. And so that's a helpful way to look at smaller burns. You can also use kind of hybrid methods. If they've got a full chest burn, you may estimate that at 18%, but maybe they just have a few spots on their arm. You may use the Palmer method to kind of calculate out 3% and then add them together. When a patient gets here and we do a formal burn wound assessment, we fill out what's called a Lund and Browder chart. And this is an example of our ANTHC initial burn chart, where we shade it in, and then it helps you determine the burn size. It breaks the body down a little bit more and also breaks it down by age. And so all burns that get admitted to ANTHC should have this filled out and signed by the attending responsible for the initial burn wound debridement. So once you have your depth and your size, then we're going to calculate our resuscitation needs. And it's important to know that large burns, or greater than 20% TBSA, are going to have increased fluid needs. So again, we're talking about burns, large burns, starting burn fluid resuscitation. Why do they need burn fluids? Well, or why do they need fluid resuscitation? Well, patients can develop burn shock, which is a hypovolemic shock, and the amount of fluid lost and the amount that you have to replace are proportional to the patient's burn size and the patient's weight. And so that's how we're going to get our estimation of what that patient needs to keep them out of burn shock. Burn shock is caused by inflammatory mediators. And so there's this huge response by the burn injury. And so fluids and proteins leak from your intravascular space into your extracellular space, or your third space, into the interstitial tissues. And so what happens as a consequence is that the patient becomes massively the hypovolemic while becoming very edematous. This fluid shift is the fastest in the first 8 hours, but can continue up to 24 hours. So this is kind of how it works. The edema formation kind of comes first. Then you're having disruption of your collagen and progressive loss of colloids into the interstitial space that will decrease your function of your capillaries and eventually leads to massive hypovolemia and multi-organ failure. So I really like this because I trained first as a trauma surgeon and then learned about burns. But this is a graphic from University of Utah, which I love. So, you know, if you think about filling up someone's intravascular volume as filling up the tin can, in trauma, we have when someone is in shock, we presume it's hemorrhage. And if you plug the hole, aka stop the bleed, you can fill that tin can up with fluid. But in burn shock, you have leaky capillaries. And so it's like poking a bunch of holes into the tin can. And so if I pour more fluid in, I can't plug the holes. And as you pour more fluid in, you can never fill the can and more fluid comes out of the can. So what you want to do when you're thinking about resuscitating someone for burns is if you think about filling a glass through a colander, you want to find that exact rate that you can pour fluid down and it will fill the glass without, if you poured it really fast, there's going to be a lot of fluid that comes out the side of the colander. So you want to just find that exact rate that you can fill their tank without contributing to worsening edema. So this has been a big shift, and this is a big push by the American Burn Association is to standardize the pre-hospital fluids that patients get. And so what we teach pre-hospital providers is that if you have a large burn, 20% or greater, even before you know the exact burn size, we just want them to say big burn or small burn. And if it's a big burn, we want IV fluids to be started at an age-based rate. So for adults, it's going to be 500 cc's an hour. For children, 250 cc's an hour, and for small children, 125 cc's an hour. So if you're advising someone in a village clinic or in a pre-hospital setting, this is what we want, is we just want a rate started, and we don't want boluses, we just want an initial rate started. Then we're going to calculate TBSA as soon as possible. In Alaska, sometimes this happens here at ANMC, sometimes it happens at an outside facility. Because of our long transport times, it may happen at different points of care. Once you have a formal TBSA, then we're going to start a consensus formula. So it's somewhere between 2 to 4 cc's. Most people are familiar with the Parkland formula, which uses 4 cc's. The Brook formula, which is military formula, uses 2. The Baxter formula uses 3. There's lots of different iterations of this, but somewhere between 2 and 4 cc's times the patient's weight times the percent TBSA burn size is going to give you their total fluid that that patient's expected to have in 24 hours. We're going to give the first half of that over the first 8 hours because we know that's when the inflammatory burn response is the greatest. And then over the next 16. So I'm going to show some examples, and for the use of this presentation, I'm going to use that 3 cc's, just the middle of the road number. Kids are a little bit different. Kids, we're going to have a lower threshold to start burn fluid resuscitation. So we're going to start at 15 cc's or 15% TBSA, but they have the same formula. That same consensus fluid rate. So we're going to calculate that out. But to note, very small children, less than 30 kgs, will require dextrose as an additional maintenance fluid. They have smaller glycogen stores, their livers are more immature, and so they become easily hypoglycemic under stress. So for kids, we always want you to check an initial glucose and then start some kind of dextrose, some kind of D5. We always have to remember in Alaska, we have CPT1A Arctic variant, which is a genetic predisposition to becoming hypoglycemic for prolonged periods of NPO or under stress. So it's really important to make sure that we start this. And for this, you're just going to start a maintenance fluid on your weight-based 4-2-1 rule. You do not subtract it from the consensus fluid rate, but put it as an additional fluid line. I'll show you some examples. Kids, the reason why they need a lower threshold to start burn fluid resuscitation is that they have a greater surface area to unit of body mass. So they have more skin per their capita. Because of this, they require greater amounts of resuscitation. They also have less intravascular volume. And so they're really susceptible to fluid overload and hemodilution. So you have to be they're in a real tenuous spot. So here's a couple of examples. Here's an adult example. This is a 25-year-old man with a scald injury, circumferential from the belt line down to the toes. He's 80 kilograms, and we have an estimate of 45% TBSA. So pre-hospital fluids, he's an adult, he's got a big burn. So I'm going to start 500 cc's an hour. Once we get that formula, that formal calculation of 45% TBSA, we're going to calculate our initial rate, which is going to be, on this example, 4 cc's times 80 kilograms times 45% TBSA. So that gives us 14.4 cc's in the first 24 hours. The way we get our rate is we divide it by 2, and then we divide it by 8, which gives us 900 cc's an hour of LR. Okay, so what if we have a kid? So this is a 20 kilogram child, again with scald burn, about 30% TBSA. So again, our pre-hospital fluids, I know this is a small child, big burn. I'm going to start 125 cc's an hour. We're going to calculate our initial rate. So 4 times 20 kigs times 30 TBSA. It's 2,400 cc's in the first 24 hours. To get our rate, we're going to divide it by 2, divided by 8 for 150 cc's of LR. Additionally, this kid is going to need weight-based maintenance fluids. So we're going to start a second line of weight-based D5 half NS, D5 NS, D5 LR. I don't care, it just has to have dextrose. And so this kid is actually going to get a rate of about 210 cc's an hour. So what happens with rural burn care? Well, we're all familiar with some of the challenges in Alaska. Often these patients will be a delayed presentation, either because it's hard to locate the patient or hard to get the patient to an area of care. With remote access, there's usually multiple transfers, long time for transport as they cross those really extreme distances. And then there's possibility for decompensation en route. There's often limited resources. I like to ask the clinics I visit how many bags of IV fluids I have, and sometimes they only have 6 bags of IV fluids. So if you're thinking about giving someone 900 cc's an hour and that patient's going to be stuck there for a while, you might have to think of some creative ways to keep that burn fluid resuscitation going. So this is a common question, is what to do if there's a delayed presentation. So again, this is that same patient. Sorry that I used 4 cc's in one and 3 cc's in the other, but this is the same patient. So we've calculated our fluid rate. We're going to get, and we're going to give them 675 cc's an hour of LR. But let's say that I told you that actually this patient was hiking in rural Idaho, and it's going to take us a little bit of time to get to them. So, so if we just said, okay, he presented at time 0, we would start our initial rate at 675, and at 8 hours, we decrease to half because we're going to give the second half over the next 16 hours. But if he presents at hour 4, what do we do? And the answer is that you're just going to start the rate that you expect him to need that hour. So you're going to start with that rate of 675 cc's an hour. You're not going to try to catch up with the 4 hours that you've missed resuscitation and bolus him in that that extra fluid. Because again, think about that colander or that tin can, if you pour it in, it's going to also pour out. So we're just going to start with his expected needs. We're going to anticipate that he may have some challenges in resuscitation, but we don't want to go overboard with fluids. And after that, we'll adjust the rate hourly based on urine output. What kind of fluids do we want? If you have the choice, lactated ringers is the best for burn fluid resuscitation. It's the most physiologic, it's close to plasma. And anticipating large volumes of resuscitation, we want to avoid hyperchloremia-induced metabolic acidosis. You will see hyponatremia in these patients, but it is tolerated pretty well. Vascular access, we want to make sure we have good access for the resuscitation. It's okay to place IVs through burn wounds. You need to secure them well. They will end up being slippery as there's just normal seeping of the of burn fluids, but also if there's creams or ointments on the area, that could be really difficult to maintain them in place. You can place an IO. That's a really great way to start resuscitation. Once a patient gets to in-hospital definitive care, they will always get central access due to the large volumes anticipated, but also the tissue edema during resuscitation. So if you do have a long transport, the IVs and IOs need to be frequently reassessed, as they can get displaced as the patient develops more edema. Oral resuscitation has largely been abandoned in the US for large size of burns, mostly because it's impractical and most patients don't tolerate the large volume that you need to resuscitate. Nausea and vomiting is to be expected. But it is feasible and favored for small to moderate sized burns. So if you have a burn less than 15% in kids or less than 20% in adults, it's really a great way to resuscitate a patient. So you don't need to go into that formal burn fluid resuscitation. You do need to consider MPO status. Knowing that most burn wound debridements will require some type of sedation, you want to be communicating with the sending team to make sure that they're keeping the patient MPO. And if so, for kids, again, remember that line of dextrose for kids. Also, oral resuscitation can be useful in mass casualty disasters or austere environments. So again, the burn fluid resuscitation, we're going to monitor the response. The initial fluid calculation is only an estimate. It's just a formula to get you in a ballpark of what that patient's going to need. And then we're going to adjust the rate based on urine output. Don't bolus these patients unless there's hypotension. And I will tell you that early on, burn shock does usually not cause hypotension. So if you have a patient early in the resuscitation that is getting hypotensive, you should consider other causes of hypotension. Make sure that you rule out other traumatic injuries for a lot of these burns, or consider other comorbidities or cardiac issues. And then do not catch up if there's a delay in resuscitation. There are patient populations that we anticipate increased fluid needs. These are patients that have associated trauma injuries, electrical or inhalational injuries, the delay in resuscitation, prior dehydration, or alcohol or drug abuse, or very deep burn injuries. So a 40% full thickness burn is going to act differently than a 40% partial thickness burn. So what's our endpoint again for monitoring or the response to resuscitation? And really urine output is the gold standard. Central lines for CVPs or PA catheters are generally not helpful, again, because a patient is going to be anticipated to be intravascularly low. And lactate and base deficit are going to be really slow to correct, so they're not reliable hour-to-hour results. Again, we're not just looking at quantity, but also quality. You can see that urine there. We can see that's bad, that, you know, we need, that patient is under resuscitated. The goal of urine output in adults is usually 0.5 cc per kg per hour. We go up to 1 in things like electrical injury, but for kids, we want 1 cc per kg per hour. Again, if the urine is excessive, you can decrease the rate by 10%. And if urine is inadequate, you're going to increase the rate by 10%. So let's say you start the fluid resuscitation at 500 cc's an hour. Over the next hour, you hear that the urine output is 10. Instead of bolusing for low urine output, you're going to increase by 10%. So you're going to increase the rate to 550 cc's an hour. So proper fluid management is critical to survival. There's really this pendulum swing. We've gone back and forth in burns about giving too much fluid or too little fluids, but you really want to find that right balance where you maintain tissue perfusion and organ function while still avoiding complications of either inadequate or excessive fluid therapy. So what does burn resuscitation look like? Well, this is if the Parkland formula really worked like it did. You'd start an initial rate, 8 hours later, you decrease it by half. But what really happens is something more like this, where initially they usually require a little bit more fluid resuscitation, but then with your urine output, you're going to start titrating that down every hour or 2 hours. And so you can see that in the end, the area under the curve is about the same. But we really want to, it's not tolerated well to just take the fluids in half. So we're going to start that rate and then we're going to start titrating down as the patient appears resuscitated. So that's that beautiful curve there, but often we see this would be a case of a failed resuscitation where you try to get the fluids down and you just can't until their inflammatory response kind of closes. And sometimes you see kind of a moderate where they initially respond, but then you have difficulty 8 to 12 hours later. So those are kind of more typical resuscitation curves for really major burn injuries. So it's important to, try to get to that nice black line, but where there's a lot of challenges in resuscitation. Most US burn centers will use adjuncts in that 8 to 12 hours when you start to see that they're coming off curve. When you are increasing fluids or you can't get them decreased on their rate, that's when we're going to think about using adjuncts. Resuscitation monitoring has really changed. This is something that a lot of burn centers are using now. This particular one is called the Burn Navigator, but it's computer decision support. This was introduced into the commercial market in 2013, and it aids in kind of a dynamic manner, giving your eyes and O's. It eliminates provider bias because the nurse just puts in how much urine's coming out and how much fluids you're putting in, and it basically tells you what to do hour to hour. When they've looked at this at large studies, both military and civilian, it shows that there's increased time that the patient spends in that target urine output range. Several studies have shown that it decreases your 24-hour fluids from like a 6.5 cc per kg per TBSA down into that consensus rate of 4. Some studies have shown a decrease in ventilator days, and several studies have shown a decrease in mortality. Resuscitation failures, again, the risk factors, we talked about some of those, concomitant trauma, dehydration coming in, also some comorbidities. Another risk factor for resuscitation failure is incorrect burn size or depth estimation. So not identifying a scalp burn or calculating it wrong and giving them a smaller percentage than they are, or not identifying that it's a full thickness burn wound. The other thing that can lead to resuscitation failure is compression syndrome, which we'll talk a little bit about. Signs of your resuscitation failure are going to be persistent oliguria, persistent hypotension, and persistent elevation of lactate. So if you have oliguria for 4 hours or more, you're starting to have a resuscitation failure. So one thing to think about is consider starting adjuncts when the patient reaches double the starting fluid rate, or if they're showing complications from edema. So if you start your burn fluid resuscitation at 500 cc's an hour and you've up titrated them to 1,000, you're failing, the patient is failing the resuscitation. So what are those adjuncts? Really, there's a lot of difference among burn centers in the US. So some of this is geographical about what we use and what's available. Colloids is probably the most common. You can use albumin, head starch, or FFP. Albumin, again, is the most common. This lowers the volumes amount needed for your resuscitation and has been shown to have a mortality benefit for large burn sizes. And basically, a pretty typical formula is that you start 5% albumin and you take, if they're at a rate of 600 cc's, all of a sudden you make 200 cc's of that albumin and 400 cc's of that LR. And that's been shown to kind of decrease the resuscitation needs. Hypertonic fluids, there's several studies showing with hypertonic saline, no big benefits seen in these studies. There are some thoughts that may decrease abdominal compartment syndrome or other compartment problems, but not huge differences in volume or mortality benefits. Plasmapheresis or plasma exchange is best within the first 24 hours. You can exchange with either albumin or FFP. We have done this once at ANMC. It's used a lot at Harborview, and it does lead to lower volumes needed for resuscitation. It increases patients' blood pressure and urine output, and can be used. High dose vitamin C, there's a lot of different studies. Again, this is pretty geographic specific of which centers utilize this. Again, leads to lower volumes of resuscitation, but has not shown any mortality or complication benefit. And then this is what I call burn damage control. You can do very early burn excision within 48 hours. So sometimes we typically wait about 5 days before we're excising burn wounds. But in very extreme cases, you can excise that burn scar, and sometimes removing that, the source of the high inflammation changes can help your resuscitation. So why do we care about decreasing fluids? Well, there are consequences to over-resuscitation. And we find that there's a social phenomenon of fluid creep that despite knowing our Parkland goals or our consensus formula, most patients actually receive 5 to 7 cc's per kg per percent TBSA. So when we accept a large burn patient, I look at what they receive from time of injury for 24 hours, and I calculate pre-hospital fluids, outside hospital fluids, and what they get here at ANMC. We do pretty well here. We actually typically are around 4 cc's, but I look at this to make sure that we're doing our job for not over resuscitating patients. They find that fluid begets more fluid. So if the first person that sees a patient boluses 2 liters and signs that off to the next care center, they're more likely to give more fluids. So it can happen at a lot of, when the patient's being transferred to multiple care centers. It's important to learn for our Operation Enduring Freedom, Operation Iraqi Freedom, the first 6 burn deaths from that were all due to over-resuscitation complications. Wasn't due to burn sepsis or, the wounds itself. It was all due to complications of over-resuscitation. Over-resuscitation can lead to total body edema, which we've talked about. This leads to compartment syndrome in extremities requiring escharotomies, abdominal compartment syndrome, which is very poor prognosis sign, and even ocular pressures requiring lateral canthotomies. We all know pulmonary complications of over-resuscitation, such as pulmonary edema, ventilator-associated pneumonia, and ARDS. And also you can get wound conversion. So if you massively resuscitate someone and you flood their interstitial fluids with edema, you decrease, you basically squeeze those capillaries and you have decreased perfusion to the skin. So you can actually convert a partial thickness burn wound to a full thickness burn wound by over-resuscitating a patient. That's what I have for you guys today. I know that was a lot, but we finished under time. And at this time, I would take any questions from the group.
I have a question for you. Can you hear me?
Yes.
Okay. Just as an example, that very first photo of the burned child with a little skull burn on the chest. I'm a big fan of your kind of gestalt, big burn, little burn assessment. And I would have put that kind of as a medium burn. And so I'm a little on the fence as to whether that child would need fluid resuscitation. I mean, if you took his hand and marked it out, it probably would come out to less than 15%, just eyeballing that. But what was your gestalt on that kid?
Yeah, that's correct, Fran. So, I would definitely, on that kiddo, I'd start oral resuscitation. If you felt on the fence, you can always start some kind of maintenance IV fluids. So for that kid, even if you wanted like D5-LR or something to give them a little, or let them drink juice to get their dextrose and give them some LR at a weight-based kind of maintenance rate. That's not an unreasonable strategy. I think burns less than 10%, you probably don't need that at all. But those medium-sized burns, the 10 to 20%, it's not unreasonable to start some IV fluids. We just don't need to massively resuscitate those patients.
Okay. And how often do you check the glucose on kids?
So for kids, you'll check it initially, and then probably every 4 hours is reasonable during a transport, especially if you're given a dextrose solution, they should be fine.
Yeah. And you just use a maintenance rate on the dextrose solution, like a regular maintenance rate?
Yeah, like the 4-2-1 rule, 4 cc's for the first 10 kilograms, 2 cc's for the second 10,
Okay,
and
yeah.
then a cc after that.
Okay. Yep. Okay, got it. Thanks.
Yeah.